Hello, everyone. Thank you for joining us today. My name is Janek Garayev, and I'm the Senior Health Information Specialist with Brain Tumor Foundation of Canada, and I'm so pleased to be online with you today. Brain Tumor Foundation of Canada strives to provide relevant and up-to-date information on brain tumors, and 3 years ago we launched the Brain Tumor National Conference, and we hosted that for 3 years, and after evaluating the impact of the first 3 conferences, we found that live streaming had a really big impact on our brain tumor community, having reached over 1,800 people through live streaming. And so with that in mind, we have created this webinar series this year in lieu of the conference, both from an impact perspective as well as a financial perspective. Our team is really excited to host the second webinar of our 2019 Brain Tumor Webinar Series today. We had over 170 people register and currently sitting at 72 people who have signed in. So thank you for joining us today across the country. Before we get started, just a few logistics. Everyone has been muted just so that we don't have background noise during the recording of the webinar. If you are having difficulties hearing us, please make sure your sound is up on your computer. The webinar will be recorded and uploaded to our website probably within the next 48 hours or so. And to ask a question, you'll see that once you've signed into the GoToWebinar here, there's a panel and there's a chat section. You can type your question there, and we will take up questions at the end of the webinar. If we don't get to your question, we will follow up via email within the next 24 or 48 hours. And we will do our best to get to all the questions as well. But before we get started, before I introduce our speaker, I have a couple, or 3 specifically, poll questions that I'm going to launch here. And the first one is, who is currently online with us for this webinar? And you can check more than one. So if you're a patient and survivor as well as a Brain Tumor Foundation of Canada volunteer, click both of them. Or if you're a caregiver, a family member, or friend, or healthcare professional. So I'll give everybody a moment to answer this. And it looks like the majority of the people online are patients/survivors. Okay, another 5 seconds. All right, looks like everybody's slowed down here with the voting. And we currently have 68% of the people who are signed in right now are patient and survivors. So thank you for that information. And the next question is, for those of you who do identify as having been diagnosed as a patient or survivor, who identifies as a patient or survivor, were you diagnosed with a meningioma, yes or no? So please click one answer. It looks like the majority of you have been diagnosed with a meningioma, and that is 84% who are currently on the website have been diagnosed with a meningioma. And last question, how did you hear about the 2019 Brain Tumor Webinar Series? Please just click one answer. So either through a Brain Tumor Foundation of Canada communication, on social media, through a friend or family, online, through an internet web search, or referred by a healthcare professional. Give you a second to answer that. Perfect. And 71% of you received information through our communication, so that's good to know. The marketing team will be very happy to hear about that. Okay, so let's get started, and I'm going to get to introducing our speaker. Originally, we did have 2 speakers booked for this webinar, Dr. Cusimano as well as Amy Baba. However, Dr. Cusimano was pulled away for a medical situation with a patient, a case study. So Amy does work very closely with Dr. Cusimano as a research assistant in the Injury Research Prevention Office, Department of Neurosurgery at St. Michael's Hospital. But with her also is Dr. Jessica Rabsky, who will be able to answer any medical questions towards the end. Amy completed a Master of Research in Brain Sciences at University College, London, and an Honours Bachelor of Science in Neuroscience and Cognitive Science at the University of Toronto. Amy has previously worked on research regarding the development of a novel cognitive memory intervention for people with traumatic brain injuries, in addition to investigating emotional memory consolidation and trauma-related disorders. Amy is now working on a quality of life study with people diagnosed with a meningioma and is focused on developing and validating a questionnaire specific to this brain tumor population. She hopes to contribute to the improvement of clinical outcomes for people living with a meningioma. Today's presentation is entitled Understanding Meningioma and the Impact of a Person's Quality of Life. Meningioma is one of the most common primary brain tumors, and as with any brain tumor, meningioma impacts individuals in many aspects of their daily life. This presentation will go over what a meningioma is and how people are impacted by this tumor, along with a discussion of current ongoing research aimed at understanding these quality of life issues better. So I'm going to hand it over to you, Amy.
Okay, thanks for that. So hello, everyone. Thanks for joining us today on this webinar. So as I've been introduced, my name is Ami, and I work with Dr. Cusimano here at St. Michael's Hospital as part of the Unity Health Toronto network in Toronto in Canada. So today joining me, I have a colleague here today. Her name is Dr. Jessica Rabsky. She's a fourth-year neurosurgery resident from the University of Ottawa, and she'll be joining me today as we talk about meningioma and quality of life. So as it's already been introduced, our topic for today, we will be exploring, understanding meningioma and the impact on a person's quality of life. So just really quickly, I will outline the learning objectives for our presentation today. So we'll be looking at reviewing what a meningioma brain tumor is, in addition to identifying how meningioma impacts people, as well as understanding the quality of life challenges and issues associated with meningioma brain tumors. We hope that after this presentation, you will have a better understanding of meningioma and its impact on quality of life. So first of all, we will go over what a meningioma is. So meningioma is the most common primary brain tumor, and it accounts for nearly around 30% of brain tumors that people are affected with. It is a tumor that can be found both intracranially and also on the spine. This can be explained due to where the meningioma arises from. If you take a look at the diagram on the right side of the slide here, you could see that there is a layer called the meninges. Over here, there's a box around it, which is essentially a membrane or a lining comprising of 3 different layers. So the dura mater, the arachnoid, and also the pia mater. It is said that the meningioma arises from the middle membrane, like the arachnoid over here, particularly the arachnoid cap cells that originate from that area. As the meninges cover both the brain and the spine, meningioma have been found both intracranially and also on the spine as well. So just some facts about meningioma here. So while meningioma is one of the most common primary brain tumors, it is important to note that the majority are benign. So this means that most of them are non-cancerous. Nearly 90% of diagnosed meningioma are actually benign. A small percentage, however, of these tumors could be malignant or be cancerous, in other words. So as you can see in the diagram here, around 15 to 20% are grade 2 meningioma, while a very small percentage, 1 to 3%, are grade 3. So the tumor grades here that we see in each of the boxes tell us about how the cells that make up the meningioma look under a microscope, whether they are abnormal or not, and also the likelihood of the speed of the meningioma tumor's growth. So for a lower grade, the cells look more normal under a microscope, and so they're unlikely to grow fast. As the majority of meningiomas are grade 1 or benign, it is generally known to be a slow-growing tumor. Sometimes an individual can have a meningioma for many years, sometimes even decades, without even realizing that they have a meningioma, because for these individuals, they may not experience any symptoms that they would indicate that they have a meningioma or that causes them to go and see a medical professional. And sometimes for these individuals, they only find out when they have an MRI scan or a CT scan for something else. So it's not unusual for individuals to find out that they have a meningioma as an incidental finding. So of course, there's always a chance of recurrence, no matter what the grade is of the meningioma. However, lower grades have a lower chance of recurrence. So I put the recurrence rates on the slides here. So in the situation for a grade 1 tumor, it's likely to recur at a rate of 7 to 25%. For grade 2 tumors, around 29 to 59%. And for grade 3 at a rate of 60 to 94%. However, it's also important to note that rate of recurrence can also be affected by the extent of the resection of the tumor. So sometimes it isn't possible to remove the entire tumor surgically, depending on where the meningioma is located. So while meningiomas can occur in anyone, studies have found that they are more likely to occur in women, with women being twice as likely than men to develop a meningioma. Meningiomas are also more common in those who are over 60 years old. Additionally, there are other risk factors that can also increase an individual's likelihood in developing meningioma. One of them is prior radiation exposure. So these meningiomas are also known as radiation-induced meningioma. For example, some individuals who have had radiation treatment earlier in their life, such as for leukemia or other brain lesions or tumors, are also more prone to developing meningioma later in life. Individuals who have been treated with high doses of radiation tend to develop meningioma around their 20s or 30s, which is much earlier than the originally cited 60 years old for those who have meningioma occur spontaneously. Another risk factor that can increase individuals developing meningioma are genetic disorders. One such genetic disorder is known as neurofibromatosis type 2, or NF2 for short. So this is actually an autosomal dominant disorder, and individuals affected with NF2 are more likely to develop various different types of central nervous system tumors, which aren't limited to just meningioma, but can include them, but also includes tumors such as schwannomas and sorts. So over here, we're going to discuss the common locations of meningioma, as we have now discussed generally what a meningioma is and where it arises from. And so, as I mentioned earlier, meningioma arises from the meninges, the meningeal layer, which covers the brain and the spine. So we can find these meningiomas on the brain as well as on the spine as well. So the diagram over here mostly goes over common locations intracranially. So as you can see, a meningioma can develop in the parasagittal area, which is towards the top of the brain, and it's near the superior sagittal sinus. Right next to it on the diagram, it's the parafalcine or the falx region, which is the groove that separates the right and the left hemisphere of the brain. Convexity meningiomas are those that form on the outer surface of the brain, which excludes the parasagittal and the parafalcine or falx area. And also, they can also form intraventricularly, which is within the ventricles of the brain, which also contain the cerebrospinal fluid. Over here, the foramen magnum is a hole in the skull base where the spinal cord runs through. So meningioma can be found in these common locations, but they can also be found on the skull base, which isn't pictured in the diagram here. But some other common locations on the skull base could include the olfactory groove, the tuberculum sellae, as well as the sphenoid wing or the ridge. As you can see, meningioma can appear anywhere intracranially and also spinally. So depending on how large the meningioma is, it could go on to affect other areas of the brain by applying pressure to these areas as the meningioma grows bigger, resulting in various different kinds of symptoms, or sometimes no symptoms at all. Sometimes the meningioma could have been there for years, but it's because it grew to a significant size that it is now pressing up against important areas of the brain, which are causing the corresponding symptoms that someone can experience. So treatment for meningioma can include a variety of different types of approaches. So sometimes all that is necessary is constant surveillance and monitoring of the meningioma, particularly if the tumor isn't very big and it isn't having a large impact on the individual. This course of treatment could entail an individual having constant follow-up appointments, either after a number of months, annually, or even biannually as time goes on, with a neurosurgeon by undergoing regular imaging such as MRI scans or a CT scan to make sure that the meningioma is stable and not growing rapidly. However, if the patient is symptomatic from the meningioma, for example, having changes in their vision, if the meningioma is continuously growing in size, or if the meningioma is bigger than 3 centimeters, or that there is a risk that a patient can lose a vital function like their eyesight or their hearing, these are all examples of important considerations for surgical intervention. Individuals can undergo either a craniotomy, which means the removal and replacement of a portion of the skull for surgical access to remove the meningioma, or in some cases, transsphenoidal surgery, which is an operation that is performed through your nose, and this all can be considered based on the tumor's location to remove the meningioma. The treatment course would, of course, be outlined and discussed between each patient and their doctor. Radiation is also another option, particularly for those who may be older, have comorbidities that puts them at increased risk if they undergo surgery, or if they don't want to undergo surgical intervention. Radiation treatment typically consists of multiple sessions. Sometimes those who have undergone surgery may not have had their entire meningioma removed due to where it's located, so they may also undergo radiation treatment after the surgery to reduce the chance of it coming back or recurring, and also control the potential growth of the tumor. So as we discussed, it can, meningioma can appear anywhere within the brain or the spine where there's meninges. So this also results in individuals experiencing a variety of different kinds of symptoms. As such, there isn't really a typical meningioma patient, as the symptoms experienced truly depends on where the meningioma is located. Even amongst those who have a meningioma in the same location, their symptomology could actually be quite different between the two. It is also important to note that not all of the symptoms that an individual experiences can be directly attributed to the tumor. With that said, there are typical symptoms that are common symptoms of meningioma, or the most common ones that people tend to present with when they go see their doctor. A recent finding found that some of the most common presenting symptoms includes chronic headaches, visual problems such as blurry vision or even double vision, onset of seizures, weakness in the limbs, such as the arms or the legs, which could cause an individual difficulty walking or result in them feeling as though they're off balance. For some, they start to have difficulty with their short-term memory or may have problems with word finding. So while this is an extensive list of symptoms, some location-specific symptoms are also apparent. So these are more general symptoms. So for the location-specific ones, for example, those who have a meningioma in their olfactory groove, they may develop a decreased or a complete loss of smell and taste. Those who have a meningioma in their posterior fossa may experience difficulties with their balance, and convexity meningiomas can result in the onset of seizures. And also for spinal meningiomas, patients may experience urinary incontinence or weakness in their legs. For some, they may not even notice their symptoms or have any at all. For example, personality changes is a possible symptom that results from meningioma, and it's actually one of the more common ones. However, for the personality changes, usually the patient doesn't notice it themselves, but it's usually more the patient's family or their friends that notice it and kind of flag that symptom. So there is no one specific profile of a meningioma patient in terms of their symptoms, but the impact that the meningioma has on an individual's life varies on a number of factors that we discussed earlier. Some individuals experience many symptoms prior to their surgery, while others may not have any symptoms at all and then go on to develop new symptoms after their surgery. While recovery is generally positive in meningioma patients, and those who undergo surgery and remove their meningioma, they are typically kind of, quote unquote, cured of their meningioma. Some individuals develop new symptoms such as onset of seizures after their surgery. So with this in mind, the quality of life in meningioma patients is an important consideration. Quality of life can also be defined as an individual's satisfaction with their well-being and their level of function in their daily life. As you can see in the diagram on the slide here, quality of life is comprised of many different aspects of a person's life. This could include social well-being, physical health, functional, emotional, personal, psychological well-being. So many patients are concerned about how their quality of life will change with their meningioma and also after undergoing surgical treatment. Meningioma has the potential to impact these various dimensions of quality of life, coupled with taking into consideration which domains are important to the individual themselves. So, for example, for someone who may love to exercise but is starting to experience weakness in their legs and are no longer able to partake in physical activities due to their symptoms, their physical health may be impacted severely, which diminishes their quality of life. For emotional well-being, the stress and the anxiety from knowing that there's a tumor in their head, or the anxiety associated with having to undergo surgery or radiation, can go on to further impact an individual emotionally, with some developing depression and having, emotional well-being impacted. For functional well-being, symptoms may become so debilitating to the point that an individual has to take time off of their work or have to depend on others to help them with their basic daily needs, such as bathing or eating. This is also true for after the surgery, when patients may need more support in getting activities of daily living completed. Social well-being can be impacted, particularly if patients start to feel that loud and chaotic environments are overwhelming for them, or some may not want to see their friends after their diagnosis, which goes on to negatively impact their social life and their well-being in that regard. While the impact on quality of life will vary across each individual, it is apparent that meningioma has the capability in affecting an individual's way of life and, importantly, their satisfaction with their life. In the previous slide, we discussed how quality of life can be affected severely in those with meningioma. However, there has been an increase in studies that explore the impact of meningioma on a person's quality of life, particularly for those who have undergone treatment. Recent studies have found that those with meningioma have a lower quality of life even after their surgery compared to those who are otherwise healthy. Notably, meningioma patients who developed epilepsy or seizures have lower quality of life compared to meningioma patients who don't have seizures. Ideally, we would observe an upward climb in the quality of life of these patients, and it returns back to what it was prior to their meningioma. But however, this isn't always the case. Quality of life can change throughout the various phases of a meningioma patient's treatment course. The impact of meningioma can start even prior to receiving the diagnosis. For example, one study found that before surgery, patients have primary concerns that revolve around their physical health, such as the ability to walk and also coordinate. Upon receiving the diagnosis, an individual is faced with a lot of information and decisions that have to be made, particularly in terms of their treatment options. For those who may be experiencing symptoms already, their quality of life would be already impacted severely for some. With treatment, individuals can experience complications, but for those who have a successful treatment, they may no longer experience symptoms which could result in an improvement in their quality of life. One study by Kalkanis in 2000 found that generally after the surgery, 80% of patients who participated in this study are satisfied with their quality of life and are able to partake in activities of daily living, independence, and level of functioning prior to being impacted by meningioma. However, this does not mean that individuals do not still face challenges even after their treatment. Post-treatment, some individuals have reported that they are still experiencing symptoms or that their recovery is going a lot slower than they expected, resulting in them feeling as though their quality of life is not very high. For many, they may continue to experience a lower level of energy for weeks or even months, which inevitably affects their ability to partake fully in other aspects of their life. For some people, their lives are affected even years after their surgery. For example, one study by Najafabadi in 2017 found that for those who had surgery at least 2 years ago, patients with meningioma at the skull base reported different issues to be affecting their life compared to patients with a convexity meningioma. Skull-based meningioma patients reported that concentration, memory, and worries were domains that impacted them greatly, while those with convexity meningioma reported concerns mostly about their daily activities such as the ability to drive, daily functioning, and transport. Others also report various residual symptoms that they continue to struggle with. A different study found that meningioma patients continue to feel more fatigued 12 and even 48 months after their surgery when compared to the otherwise healthy population. So there are specific research studies that have been conducted to investigate quality of life in meningioma patients, as discussed in the previous slides in regards to quality of life. Another recent study found that after surgery, patients who have undergone surgery report having lower physical and social roles during the 1 year immediately after their surgery when compared to those who don't have a meningioma. Another study found that meningioma patients with epilepsy have lower quality of life compared to patients who don't suffer from seizures. The current research, however, is limited in exploring quality of life in meningioma patients thoroughly. The heterogeneous characteristics of meningioma patients is highlighted in a study that looked at the different quality of life questionnaires that are available now and its relevance to the meningioma patient population. The findings found out that healthcare providers and patients rated different quality of life questionnaires to be relevant. However, this is kind of troubling in the sense that many quality of life questionnaires are developed without taking into account the perspective of the patients themselves. This points to a limitation in the tools that are available in assessing quality of life in the meningioma patient population. Currently, there is no specific quality of life questionnaire that is specifically designed to address the issues that are voiced by meningioma patients and experienced by them. Right now, generic quality of life questionnaires are being utilized to assess quality of life, but this is limited in the sense that it doesn't capture the particular symptoms and issues that the meningioma patients may face. This is coupled with the challenge that many patients experience different kinds of symptoms. As such, there is a necessity in developing a tool that is specific for the meningioma patient population in order to be able to capture the quality of life issues in this patient population throughout the course of their treatment. This tool would help in understanding the patient's perspectives as well as their values, but also support patient and clinician decision-making in meningioma management. Importantly, a tool like this would be helpful in identifying further resources and supports that could be developed to help this patient population. And as there is no one single typical meningioma patient, a tool like this could also be used by clinicians to understand each individual's unique experience with meningioma. Developing and validating a questionnaire with input from the patients is of the utmost importance, as patients are the ones with the lived experience. As such, our team is currently conducting a quality of life study where we are working on developing and validating a meningioma-specific instrument. By involving patients, we seek to understand the issues that patients themselves have identified as important in order to develop an instrument that is relevant to this patient population. Therefore, we are reaching out to individuals who are impacted by meningioma to provide their input and feedback on the questionnaire that is being developed by our team. If you are interested in participating or contributing or learning more about the questionnaire that we are developing, relevant information will be made available on the Brain Tumor Foundation of Canada's Research Participation Opportunities page in the near future, where there will be more information on this study. So as a disclosure, I do want to mention that this study is conducted with the support of Cancer Care Ontario through funding provided by the Government of Ontario. And lastly, as a note, if you have any medical specific questions pertaining to yourself or a family member or others, please consult a medical professional. And thank you so much for listening. Here are the contact details if you want to reach our team. There's a telephone number and also an email address. So thank you so much.
Thank you, Amy. That was a wonderful presentation and lots of really, really great information. We have some questions that have come through, so let me just open these up for you. Okay. The first question is, how different is a brainstem meningioma in regards to symptoms, surgery, and quality of life? Dr. Radsky, do you want to take that one, or Amy, are you going to take that?
So hi, everyone. I think, Ami, you touched a little bit on this already. So I think the important thing to emphasize too with meningioma that you went into very much detail, which was great. You explained that it comes basically from the leptomeninges, which is the covering around the brain. And so it doesn't originate from the brain stem itself, but it originates from this layer that covers the brain. And so it can be located, like you said, in the skull base or posterior fossa, and this can cause pressure or compression of structures that are around the brainstem or part of the brainstem and can push on the brainstem. And so this can cause various symptoms, and it depends on the location. So I think on a case-by-case, the presentation can vary quite a bit, but there are some really important vascular structures or cranial nerves, so just vital nerves that we need to help us hear, help us have sensation to the face, and various functions like that. So I think the presentation can vary quite a bit. The severity of that, I think, is on an individual basis. So I can't comment on it being more severe than another, but there's different factors that obviously affect the severity. So, the age of the patient, we always have to consider the size. If it's very large, it may be more difficult to remove. The patient's overall health. And then again, what structures is it compressing on the brainstem? Is it compressing on the nerve that supplies hearing? Because then that might be a risk for your surgery that we would have to disclose to you, potential, damage to your hearing, damage to the sensation of your face or movement of the face. So it's all case by case. And I think everyone's presentation can vary wherever meningioma.
Great, thank you, Dr. Radsky. Another question is, I'm one who has had an astrocytoma meningioma removed and then grew back 3 years later with prior radiation. I also have NF1. Does that make me more at risk for future tumors?
So it does place you at risk for, yes, so the short answer is yes, because you have, there is this history, this congenital history, because if you have a diagnosis of NF1, it does put you at higher risk of having tumors. Normally meningiomas are associated with NF2, but they can be associated with NF1 as well. But normally we see it with NF2. And so it does place you at higher risk in general from the average population. So that's why surveillance, ongoing surveillance, is also important. But obviously, I leave that to the discretion of the neurosurgeon that's following your case, because they can choose, based on your subsequent imaging, they can make that decision as to how often to follow your case.
Great, thank you. Another question is, are the recurrent rates you posted for grade 3 with surgery radiation treatment? Can you provide any additional resources on recurrent of grade 3? Does that make
additional resources?
Yeah. Sorry, go ahead.
So, yeah. Sorry.
No, go ahead.
Oh, okay. So for grade 3 specifically, so off the top of my head, I think that's something that we could get back to you all and post on the website for additional resources, so you can compare different recurrence rates, because many papers will, they're different recurrence rates, because it also depends on the extent of resection. So I think it's also a case-by-case thing that you need to sit down with your surgeon and discuss, depending on how aggressive the resection was, where the meningioma is located. So all those things factor into recurrence rates, but specifically for grade 3, we could provide some additional resources for that. later on.
Great, thank you. And we can post that on our website, or I can email it to the attendees as well. Another question is, can individuals work when going through radiation? I imagine this is probably a case by case, depending on energy levels, or?
Yes. So I would agree. I think it depends on the radiation treatment that you've agreed upon. So some are fractionated doses, some are single-time doses. So it depends on the course that you've selected with your radiation oncologist. So I think that's also very case by case, and it also depends on your symptoms and how you're feeling. And each person, obviously, like we've talked about today, can have different symptoms. And so I think it is a case by case scenario.
Mm-hmm.
Yeah.
Thank you for sharing that. A few more questions here. Another one is, can you expand on the types of seizures experienced and the treatments available? Why are seizures not triggered prior to surgery, post-surgery, and are finally experienced a year later after the meningioma started regrowing and was treated with radiation?
Okay, so that's a tough question to answer. Seizures, so depending on the location of your seizure, so some patients can present with seizures as their chief complaint, so that can be what initiates their first scan, let's say. And so then those are usually attributed to more cortically located meningiomas, so on the convexities, parasagittal sinus, around there, those locations. So you may have a predisposition to having, because of the location of the tumor, you may be already experiencing seizures. And then also with surgery itself, it is a common post-operative, I don't want to say complication, but it does happen frequently after surgery where a patient can experience a seizure just from the surgery itself. This doesn't necessarily mean that the patient will then go on to have ongoing seizures for the rest of their life. It's very commonly associated with the surgery itself and then can get better. To present later on and having not had any seizures prior or post-surgery, and then a year later having a new seizure coming out of absolutely nowhere, I would recommend at that point, obviously following up with your surgeon, because this may or may not be a sign of recurrence, but I would signal that and just let my neurosurgeon, I would let them know, just so that you can maybe have a repeat MRI and see what's going on.
Okay, great, thank you. We'll just go through a couple more questions. There are quite a few that have come through. A lot of them are a bit repetitive in the sense of same topics. So there were a couple of questions regarding medical cannabis and CBD oil and any research on shrinking brain tumors. I'm not sure if you can comment on some of the research that's been done.
So with regards to cannabis and shrinking meningiomas, I don't have any current information or references that I could attest to say that that's the case. So currently there aren't any specific guidelines or any papers that we have acknowledged yet in our profession that would put that as part of the treatment. So I wouldn't make a statement saying that it would shrink the tumor. However, in conjunction with symptom management as far as pain management, that's something you can always explore later on with your neurosurgeon or your pain management team. But as far as having evidence that it shrinks tumors, I don't have any references to that, nor have any of my colleagues ever alluded to or suggested that as a form of treatment.
Okay, yeah, that makes sense. Can good nutrition and supporting the immune system aid in the health of a meningioma patient?
Definitely. So I think that's an important thing for all patients to be aware of, any surgical patient, because especially if you're going through a treatment that involves surgery, is that you really want to optimize your ability to heal effectively and really optimize that for yourself. So proper nutrition and taking care of yourself from that perspective really helps with the wound healing and helps reduce your risk of infection and post-operative infection and obviously complications. So I think as a whole, I recommend that for all of my patients prior to any type of surgery.
Thank you. And we'll do one more question. Let's see here. There's quite a, I will just say to the audience, there are some questions where some of you kind of go into detail about your medical history. It is very difficult to go through those types of questions through a webinar, so I will follow up with you directly and see if we can get some answers for you. What's the likelihood of people getting multiple meningiomas? Are there some statistics around that?
So statistics off the top of my head, I'm hesitant to quote any right now. Sure. There are certain risk factors that increase your likelihood of having meningiomas. One of them being obviously, like we've heard from one of our webinar participants, so an NF2 diagnosis, so neurofibromatosis would be a predisposition. I think Ami also went into detail in one of her slides, any previous radiation treatment. So particularly in pediatric populations, so patients that have survived previous diagnoses of cancers and have undergone radiation treatment, one of the side effects of radiation treatment further on in their life, they say about 20 to 40 years out, there's an increased risk of meningiomas. Okay. So there are certain populations that have a predisposition to that, yeah.
Okay. So I'm going to ask one more question if that's okay.
Okay.
Are CT scans as good as MRI? If you have a cochlear implant, is there anywhere you can get an MRI?
Okay.
My understanding is that the machines now can are okay with those types of implants, but I think back in the day there were some issues with people getting scans. Is that true, or is that a myth?
So unfortunately, I'm not super. I don't know about cochlear implants per se. I haven't come across that issue. I'm only in my 4th year of neurosurgery, so I haven't come across a patient with that issue. However, I can speak to having any other metal objects or stents or certain things like that, which end up being an issue with MRI. So MRI, it's a very different modality of imaging than CT scans. CT scans obviously have a component of radiation, whereas MRI do not. MRI helps visualize brain tissue and brain matter more effectively than CT scans. However, if you have metal in the body, then you may not be able to receive an MRI and then have to have a CT scan performed. So I think that's the best question to answer that would be so what I always do is I ask our MRI technologists. And so sometimes they can modify certain things, or they can look into the device that has been implanted. So if you have a serial number or a code or some sort of model information, you can provide that information to the MRI technician, and then they can see if their MRI is compatible or not with the device that you have implanted. Okay. That goes for all stents and all other hardware that has been put into patients.
Sure. Are you able to talk about the risks of the gadolinium use in MRI? Are there risk factors with using that?
So risk factors for gadolinium. So honestly, I don't think there's been any like concrete evidence to say that, you know, after so many injections with that, I have not come across any to say that it is harmful. It hasn't really, to be honest, I haven't really been concerned with using a gadolinium. It's very commonly used, and many patients have gone through multiple scans having it with no known side effects or that we're aware of. So I personally am not aware of any imminent risks for gadolinium.
Okay, thank you. Thank you to both of you for joining us today. Thank you, Dr. Rabsky, for sitting in for Dr. Cusimano. Please say hello to him for us. Ani, thank you so much for your presentation. It was wonderful with a lot of really great information. Just a reminder to everybody, I will follow up to answer the rest of your questions via email. So Dr. Rabsky and Ami, I might touch base with the two of you quickly via email in the next couple of days that maybe help answer some questions for me. That would be really helpful. And I'm going to just switch myself to be presenter for a moment so I can show the audience a couple of things on our website. go. So here is the main page of Brain Tumor Foundation of Canada, braintumor.ca. You'll see here on the left-hand side is the full webinar series. So this is where the webinar recordings will be. So it's the same page that you would go to register for the webinar. And my system is obviously very slow right now with the internet. My apologies. So that's not working. So anyway, you will just go to our website for that information on the main page. And then also a reminder that the registration is open for the 2019 Brain Tumor Walks across the country. So we encourage you to register and to get out there in your respective cities to walk and support those who've been diagnosed. And we also have a lot of really great information up. Oh my goodness, my website here is not... I'm frozen. Okay, so anyway, braintumor.ca, check it out for more information. Lots of great resources, lots of great programs that we have across the country. Once again, thank you to the both of you for spending time with us today and taking time out of your busy schedules to educate us on meningiomas. And thank you to everybody who has signed on. We ended up having close to 100 people that had signed on of the 170 or so that registered. So that's a really great attendance rate. And all the best and have a great day, everyone.
Thank you.
Thank you.
Thank you.